各位长官、各位来宾、各位微创脊椎学会的会员、先进同好们，大家好。2019年台湾脊椎微创医学会第8届会员大会暨学术研讨会，今天在台中总举办，正式开始。那在正式的会议之前，我们恭请我们尊敬的高明健教授，是不是来帮我们讲一下话？我们大家欢迎高教授，谢谢。
这大会的李理事长，以及在座的脊椎外科的专家以及各学会的，已经都当过理事长。那今天很荣幸，也高兴有机会应邀的这个这么重要的一个会议，讲几句话。那么也非常钦佩这个李理事长这个承办这个大会里面出来等我们自己国内的优秀的专家以外，还邀请了日本或是韩国的一些关于 Spinal Surgery 的专家来与会，共襄盛举。那么记得我在当住院医师的时候，其实这个脊椎外科也没有说分骨科或是神经外科，但是骨科的医师比较有先见，在早期这2000年以前，就这个成立所谓的台湾Spinal Surgery Societies。那么当时主要是以骨科医师为主。那么后来神经外科医师因为没有机会参加这个会，所以在2003年，我们这个神经外科医师也成立这个台湾的 Neurospine 的 Societies。现在在座的很多都是这个创会的这个member， 而且是当过理事长。那么可见这个脊椎外科在这20年来是蓬勃发展。从我们开始的时候都是用肉眼的开刀，到显微镜，到内视镜。那么从这个脊椎外科、骨科、神经外科，现在甚至成立2个 Endoscopic 的 Spinal Surgery。那么可见台湾的这个外科医师在这个 Spinal Surgery 上面非常着力。那么随着时代的进步，各种仪器、各种这个材料的发展，各种技术的开发，就使得我们的台湾的这个 Spine Surgery 的这个领域蓬勃发展。不但在亚洲，在国际上面有很好的成绩。比如说我们陈建明医师，或者是我们荣总的吴医师，都是在国际上也占了一席之位。那么非常高兴我们骨科医师跟神经外科医师大家能够融合在这现在已经到第8届，把神经外科跟骨科医师一起来，大家共同努力互补优势，能够把台湾的这个神经外科的领域发展得更快、更蓬勃、更成熟，在国际上面发挥我们的台湾的能量。那么今天也非常感谢李理事长在这么好的地方我刚才进来的时候非常热闹，这个厂商也非常热心，在积极来赞助这个活动。我想今天在座的话，一定都可以享受到很好的一个学术上的一个节目，可以获益良多。那么祝大会圆满成功，大家身体健康，谢谢。
谢谢高教授给我们的勉励。那接下来我们欢迎台湾脊椎外科医学会理事长牛志健牛理事长上来帮我们致辞，谢谢。我们欢迎牛理事长。
李理事长，各位尊敬的前辈，还有各位就是尊敬的那个微创脊椎外科医学会的会员们，还有同好们，大家早。今天这个会我很高兴被邀请来担任这个一个来宾因为我想这个会大概是我们现在台湾唯一就是我们骨科跟神经外科脊椎的专家们能够共同讨论的一个比较重要的一个机会一个会议。那当然，我相信这个微创现在目前这个趋势上来讲是越来越变成一个重要的一个地位。那当然我就是很高兴能够来这边学习，那也希望这个会议能够顺利成功，谢谢。
谢谢牛理事长的勉励。接下来我们欢迎台湾神经脊椎外科医学会理事长黄文成黄理事长来为我们致辞。我们欢迎黄理事长。
高教授、各位李理事长，还有所有现任很多理事长，还有即将担任理事长的，大家好我是台湾神经脊椎外科医学会黄文成。然后我想这个 昨天开会听到这个理事长报告，这一年来这个神经脊椎微创医学会办的活动，真的让我们非常的汗颜。这一年实在是办了太多的活动啊！我想台湾的脊椎的手术，在目前的情况下，我想昨天早上那个健保署又开了一个会，所以事实上我们这个脊椎手术的医疗环境，事实上可能会越来越的艰困。所以我想接下来我们台湾这3个主要是 Spinal 手术的学会，包括这个脊椎外科医学会，然后脊椎微创医学会，还有这个神经脊椎会，就我们讲这3个学会，我们应该更加努力的合作，然后我们互相合作，然后再跟那个健保署，我们看能够替我们所有从事脊椎手术的医生，能够创造一个更好的医疗环境，让我们以后的这个脊椎手术能够更蓬勃发展。然后同时也祝今天的大会能够圆满顺利成功。谢谢。
谢谢黄理事长给我们的勉励。那台湾脊椎微创医学会能够成长茁壮到现在，也是我们从之前第一届历届的理事长跟各位的先进，共同努力完成。那所以我们几位的前理事长，我们第一届是徐少克徐医师，那第2届是第二届前理事长高振兴高医师，第3届于尚文于医师，我看于准有在这边，是不是请他来帮我们勉励几句话？谢谢于医师。那第4届是我们神经外科沈炯琦沈主任，然后再来下一位是张明超张部长，张部长是不是请上来帮我们勉励一下？好，那我们谢谢张部长。接下来下一任是王超然王理事长。那接下来是第7届上一任陈先的陈理事长，陈理事长说要把，谢谢。那我们就恭请我们现任第8届理事长李正宏部主任上来跟我们致辞。我们欢迎理事长。
高教授以及各位前理事长，还有黄文成理事长，还有牛志健理事长，大家早安。没有预期很快就轮到我讲话了。我想我们前理事长都很客气哈，都在下面哈，不是很，其实他们对学会的贡献很大，今天才能够到学会这样走入第16个年头。这16个年头，其实我只做1年。这1年来，其实我感觉到这个学会其实是非常的蓬勃发展，那压在身体的重担也很重，这样。可是我这个人的个性是，当你把我压得更重的话，我也想抬起来，因为从小我就想玩举重，所以其实我就办了好多的活动啊，都是 cadaver course 这样子。大家可以看，等一下在会员大会可以看到我们办了。大概有7个 cadaver course， 有2个，一个春季会，一个秋季会这样子。那办这么的活动，其实就是有很多，可以看很多学子，他们很专心，在钻研到一些 technique 一些技巧上，还会跟老师做一些 interaction 的一些对答。那我觉得，其实台湾还是有救的。就像最近我派我的学生去 Dr. Lanky 那个地方，那是 deformity 大师，同样的大师，他们学回来，而且他们在赖上呢，他们说老师真是太精彩了，我从来没看过这么精彩。我看了也很感动，说我很想去，因为我去1个礼拜，我看的都还看皮毛。他去2个月，他看到的比我还更多。我说那你就每天拉一个 case 回来，我们就烂上讨论这样子。所以现在电子也很方便了哈。所以说因为电子方便的话，我们在我们的这一届的这1年内，我就积极想办一个我们的微创脊椎的一个学术平台。这个平台可以把我们今天的这个演讲者的演讲，把你的 video 都 po 在我们的网络上，假如你今天听得不清楚，回去点上去就可以了。还有我们有可以说病例讨论会，还有一个就是我们一个专题演讲。专题演讲可能我们要请摄影师 到各位的就各位的医院里面去啊，特别跟你录起来，然后你可以美美漂漂亮亮的，或者可以把你的一些很好的想法，就在我们的网站上这样登录这样子。那现在不仅不局限在微创脊椎，我们还想扩展到那个脊椎外科以及台湾神经脊椎外科里面，希望两位理事长能够同意。我想我们把这个平台一起建立起来的话，那我们台湾的脊椎就是我昨天讲的，就是台湾的唯一哦。大陆有唯一嘛，我们也有唯一网。唯一网的话，就是我们要脊椎的话，我们上这个网路去看一下，我们现在台湾进步到哪里？也许有些更进步了，在上面连就连得很快了，这样子，可以知道我们国内的情形，也可以知道国外的情形。那这个我可能要把这个责任再交给我们下一任的理事长，不过我还是会亲自来督导这个工作，因为是我起的头，我也不想他1年就掉下来这样子哈。我希望他能至少维持2-3年，让他运作了盛行了以后，我们什么时候可以改完以后，可能可以变成一个比较标准的一个形式，让大家可以使用这样子哈。好，那今天的演讲者很多，我们也请到很多的国外的学者。第一位学者就是我们的 Dr. Ito。Dr. Hyeun Kim, please stand up. Yeah， 请大家为他鼓掌哈。我们今天的国外的学者哈，这个可能都不止讲1题啦，但是我们也花很多钱啦，至少2题、3题啦哈，所以我们题目当然比较多哈。那第二个是 Dr. Ito 啊 ，Dr. Ito, please stand up. Yeah。谢谢，他们都贡献很多的题目哈。第3个就是 bipolar 的大师啦哈 ，Dr. Joy， hey stand up， thank you。他讲3个题目了哈，他是毫无这个保留了，就讲 bipolar。现在真的是从 one portal 到 bipolar， 所以很多学者我讲还是学子对这个题目也非常的喜欢这样子哈。我们尽量把大家最favor 的一些 topic 放在我们的医学会上。那大的会场有这个大会场可以容纳500个，下面的会场也可以容纳200个，都是很大的会场，都可以视野啊怎么样啊，都可以让你看到非常的清楚哈。好，那我今天就讲到这边，同时我也祝今天大会非常的顺利、圆满、成功，谢谢。
谢谢理事长的勉励。那我们的演讲就开始，我们请第一个 section 的座长就座，谢谢各位。
It is my pleasure to welcome all of you and the foreign and domestic speaker to be here. And I'm Dr. Chen from China Medical University, Taichung. And Dr. Jamin Chen is from Jianghua Christian Hospital. And Dr. Fu Zaisheng is from Chang'an Memorial Hospital in Linkou. We are be in the chair in this section in the morning. And the first speaker is Dr. Kim. I think Dr. Kim is very, very famous for us. It is a very famous endoscopic spine surgeon in the world, and he has a very, very good friendship with our member and our society. So the first topic will be delivered by Dr. Kim. Dr. Kim, please. I'd like to give him a very, very warming welcome to Dr. Kim.
Okay, thank you, Chairman. Good morning, ladies and gentlemen. I'm Hyeun from South Korea. I have 3 lectures today, and also it is my great honor to give a lecture in Smith. First, my topic is for endoscopic ULBD for lumbar spinal stenosis. This is my curriculum by 10 disclosure. Yes, before time, we perform so many spine surgery, but nowadays we checking the the people's mean life increased so much, and also some treatment modality and target is some changed. Before time, the main topic is lumbar disconnection and lumbar herniated disc is main pathology, but nowadays lumbar stenosis increased so much because of that. Nowadays some endoscopic spine surgery also changed from the lumbar disconnection to spinal stenosis. Yes, we already well known that the first time we starting the open spinal surgery, but there has some complication and some limitation. Because of that, we starting the microscopic spinal surgery for minimizing the damage of the structures. But still, there have some complications, and we hope to take a more minimized option and minimize damage and or good clinical route to the patient that we change it, now move to the endoscopic spine surgery. And also endoscopic spine surgery first is starting from the transforaminal approach, but after they move to intraminal, after then endoscopic decompression, and nowadays we nowadays we're going to the endoscopic fusion generation. Actually, this generation can be divided two generations. One generation is the discectomy generation of the endoscopic spine surgery, and nowadays endoscopic decompression and fusion generation. It's meaning that before time we targeting the disc herniation, but nowadays change it to the stenosis. But we should checking the why we move to from the minimal microscopic spine surgery to endoscopic spine surgery. There is a rationale. And firstly, we should checking that actually the endoscopic disc pathology is some pointed pathology. Only we can treat that pathology by the endoscopic transfer, only remove the pathologic point. But actually in the stenosis, some different pathology. There has some relation with the instability. Because of that, not only decompression, we should always checking the how to keep the stability and how to keep the around the structures without damage, and with take a good decompression and good clinical result. Because of that, we can see here the actually this stenosis, and one day after operation you can see this image. Before time endoscopic spine surgery, we firstly thinking that minimize the option and the early recovery and some cosmetic effect, but actually you can see here our real rational policy of the endoscopic decompression is that you can see here the bilateral facet joint preserved completely and paraspinal muscle completely and rare decompression. It's meaning that we should checking the sufficient, in spite of the sufficient decompression, but we should take a preservation of the functional segment, the bilateral facet joint and the paraspinal muscle, and all structures saving is the rationale of the endoscopic decompression. And also, many doctors talking that why you move to the endoscopic decompression. Because of that, previously we used tubular decompression, and that also take a good clinical result compared to the previous. But why you should move to from the microscope to endoscopic decompression? You can see here, not only some minimized damage. There have some another point is that endoscopic decompression has a more mobile and angled. Because of that, we can search the more deep, more detailed point. And another point is that some searching point is more deepest near around the target point. Because of that, we can manage the more detailed pathology under the more clear view. There is some different compared to the microscopic decompression. Not only some preservation of facet joint. And also, actually, during last 3 or 4 or several years, the scientific report already published so many papers. This is my paper, and some another paper already published. This Ito's paper, Fujo Ito's paper. And it means that nowadays the endoscopic decompression scientifically already published so much, and it already based on the scientific base. And first, we're thinking that the anatomical consideration of the endoscopic decompression. And also, here we can see some classification of the endoscopic decompression, uniportal 2 and biportal 1. Actually, uniportal also can divide the inside out and outside in. Actually, this outside in some other doctors talking that over the top technique, but I would recommend the outside in technique because of that. Actually, this inside out technique is more easy for the beginner, but outside in technique is more difficult. But if you overcome the inside to outside in, you can apply the all point of the stenosis in spite of the thorax and cervical. Because of that, nowadays my operation. In my clinic, my operation is every month 50 cases. Among them, the more than 45 cases endoscopy surgery. It's meaning that if you move from the open surgery to endoscopic surgery, firstly thinking that the good clinical result, and second things is the safety. But if you give the safety, the outside should keep the outside in, that you can give the safety of the thorax, safety of the cervical can possible. But and also good clinical result, sufficient decompression can take from the outside in technique. The meaning of the inside out is the first insert the endoscope to the epidural space, and then resection of the ligament flavum. The outside in firstly drilling around the ligament flavum, and finally take out the ligament flavum, and that decompression finalize. There is some different. I use the outside technique, and also some another anatomical consideration of the endoscopic decompression is the structure of the ligament flavum. Yes, we already well known that the outer layer, ligament flavum divided two. One is the outer layer, one is the inner layer. Firstly, starting the endoscopic decompression, we believe that the decompression of this outer layer is sufficient for the take a sufficient decompression. But actually, in our so many experiences, that is not insufficient because of this inner layer more deepest and more Freeman and more cranial. Because of that, if we not detach the inner layer, that always take insufficient operation. Because of that, you should checking the inner layer of the ligament flavum. That is very important. And also, if you hope to approach from the contralateral frame, you should checking the anatomical structures of these inner layers is very important. And also, I already mentioned that to give the safety over the top technique and outside in technique, you should checking this technique already published so many papers, and Fujo Ito already published this same technique by the name of step-by-step sublaminar approach. And also in the endoscopic decompression, there has two approach route. One is a translaminar approach, and one is a sublaminar approach. But I already mentioned that their inner layer of the ligament flavum is very important. Because of that, we approach not damage the around the structure with the sufficient detach the inner layer. This sublaminar approach is more benefit. And also, you can see here some surgical process of the drilling point of the outside in technique. Firstly, drilling from cranial part, and then caudal part, and over the contralateral side cranial, and then contralateral caudal drilling. Then take up the ligament flavum of the inner layer. This drilling point of the outside in approach, and then if you hope to approach from the contralateral foramen, you can drill some more deepest point of the contralateral foramen. Then you here this 3-point V point is very important in the outside in over the top decompression. You can see we already well known that this V point, but still there have some another 2 V point of the cranial and the caudal midline. If you match the cranial and caudal V point, there is meaning the center of the ligament flavum. You can see here the ipsilateral and cranial and caudal. Here you can see some shape of V and shape of V. It's meaning that the midline of the ligament flavum. And that I'm also already talking that if you give the safety operation of the, in spite of so severe spinal stenosis and cervical thorax, you always keep the over the top technique like this. Outside in is very important. Checking the 3-point and detach the cranial ligament flavum is very important. Now we see some animation of the 3D endoscopic decompression of the outside in approach. Here pathology. And firstly incision and then serial dilation. Then firstly docking to the V point and drilling cranial and caudal and contralateral cranial and caudal. And the final detach the cranial ligament and finally removal of the inner layer of the ligament flavum there. And this surgical procedures of the ipsilateral cranial drilling and then checking the V point of the midline of the cranial and caudal and contralateral outer layer detachment of the ligament flavum, then detach the cranial ligament flavum, and the final decompression of the contralateral and ipsilateral. And if you hope to approach more deepest point of the contralateral foramen, you can change the working channel. Sometimes channel in channel technique, or sometimes channel switching technique. Channel switching technique means that firstly decompression of the big working channel, then change the small working channel, same skin channel. Then insert small working channel can more easily approach to the contralateral foramen. And also, some another anatomical consideration is the contralateral foramen. You can see here if we approach it to the contralateral foramen, you can see this figure. Firstly, you can see this axilla, this dura and axilla, and this contralateral dorsal root ganglion and this contralateral foramen. If you remove and decompression to here, you can see here the contralateral dorsal root ganglion and contralateral extra foramen. And I will see some clinical cases. You can see here the very severe spinal stenosis with 80-year female patient. I already mentioned that if you give the outside-in approach, you can take a good clinical result in spite of this so severe spinal stenosis cases. Now see some surgical procedures. I already mentioned that first, this is some surgical steps of the. Firstly, drilling the cranial part, then caudal part, ipsilateral caudal, and over the contralateral caudal and cranial. Then firstly, we docking the ipsilateral V point is this V point. Then move to some more cranial point of the drilling of here. Then checking the midline, this V point, you can see here some splitting of the ligament flavum. Then you can see some caudal drilling there. And this spinal lamina angle here, and here is a V point, and here meaning the midline of the ligament flavum. Then you can over the contralateral side, still here midline, and now then we over the contralateral side, then detaching the contralateral ligament from the lower lamina to cranial. Then you can now some from lower lamina to detaching the outer layer. Then you can take out the contralateral outer layer. Then you can see the now drilling the contralateral lamina here. Then some rotation of the working channel. You can see the some contralateral lamina and a facet. Then after drilling the contralateral and ipsilateral sufficiently, you can detach the now can possibly detach from ipsilateral and contralateral. Here is the ipsilateral detachment of the cranial. Then detach from the cranial to caudal. Detachment also from cranial to caudal is very important. But if you firstly detach the caudal, that many cases can some shrinkage of the ligament from to cranial. Because of that, you cannot resection of the cranial part not easily. And this is contralateral ligament flavum resection. And finally checking the contralateral side and ipsilateral side. That is a final. And also if we doing like this outside in approach, you can see possible, like so severe cases can possible decompression sufficiently. And also if there are combination of the disc herniation and stenosis, you can use the channel switching technique. Then you can some decompression and discectomy can possible together. And also these 4-level cases L1 to facets to 2, 3, 4, 5 spinal can possible by one step approaches of. Actually, this patient received by 2 skin shunt. And this image is 6 months later follow-up image, MR image, and you can see here the 2 skin shunt. And this operation needed 160 minutes. But to developing the endoscopic decompression more fastly, it needs some developing of the drilling system, and the radio frequency system is very important. And also you can see here this case is also very interesting case. You can see here some spinal stenosis and foraminal stenosis and extraforaminal stenosis. This case is very difficult cases before by the endoscopic spine surgery in need of fusion surgery. But if we approach from the contralateral foramen, you can possible this case is by one steps of the contralateral foramen like this. Then you can see take this image. And also this case is near similar to in the foraminal pathology is very important of the stenosis. Because of that that is not easy treatment before and still not easy because of here not only one root compression, there was a triple crush pathology here. Okay, you can see that this triple crush pathology. Because of that, if we manage only this one point, the patient, many patients can remain the symptoms. Because of that, we should treat this all pathology by the one steps. If we can possible to approach from the contralateral decompression, it is possible. And also this patient, in spite of the degenerative scoliosis, this image taken 1 year follow-up, the patient still have no pain. Yes, but there still have some complications like this huge dural tear. But fortunately, endoscopic spine surgery still have so many complications like some hematoma and some fluid collection and infection and dural tear. But most common and most serious complication will be the dural tear. You can see here this case is so huge dural tear. But fortunately, if we catch the dural tear during the operation and insert the patch here, the patient usually have no complication. You can see this image taken 6 months later, the patient have no pain. Yes, in conclusion, endoscopic spine surgery is still going on stage, but I believe that in the future, endoscopic spine surgery will be the mainstream, and that will be the real good clinical result and good life for the patient. Thank you for your kind attention.
Dr. Kim, please go ahead the second. Topic. There will be a 10 minutes open discussion at the end of the section for any presentation.
Okay. Thank you so much. I will going on the next lecture of the cervicothoracic decompression. Okay. This is the outcome of the full endoscopic ULBD in cervicothoracic stenosis. I think that maybe after developing the endoscopic spine surgery, nowadays endoscopic discectomy from cervical, thoracic, and lumbar overcome near completely. But stenosis is now going on the some development, and lumbar is near overcome. But thorax also mostly overcome. But cervical still going on state. But I'm also have some many experience of the cervical and thorax. But I hope to talking that some. Before previous lecture, I talking that if we going on the real endoscopic spine surgery for all degenerative spinal disease, it need firstly success and second is a safety. But in the cervical, the safety issue is very important. I'm also have one case is some complication I will talk today. This is my correct and and disclosure. Yes, I already mentioned that with the increasing the life, the people's spinal disease pathology increased so much, and also cervical disease also increased so much. But before time, cervical pathology is not common, but nowadays with the increasing life, the cervical pathology is so much. We then need some treatment, some operation, and some endoscopic spine surgery. Also, but before time, cervical surgery has so many some limitation and complications. Because of that, cervical surgery is not performed commonly for the safety, especially safety. But because of that, nowadays the tools for endoscopic spine surgery developed nowadays. But still, I believe that still not endoscopic cervical approach surgery is going on state. But if we reach the real overcoming learning state, I think that maybe will give the more good clinical result compared to the open surgery. But fortunately, there have some advantage compared to the open surgery. Firstly, is we can approach to the directly to the target point in spite of the anterior approach and posterior approach all can possible. Mostly in the previously we performing the endoscopic anterior approach in the cervical area, but there have some complications and some limitation of indications. Because of that, nowadays many doctors change it to the posterior approach. But posterior approach also we already knowing that if we doing the open surgery, it needs some muscle damage and it make some kyphosis. There is some problems. But fortunately, endoscopic spine surgery has no muscle damage. Because of that, we can keep the not aggravation of the kyphosis in the cervical operation. You can see here that after operation, there have no muscle damage. That is the first advantage of the endoscopic posterior approach. And also some another advantage is facet joint preservation with sufficient decompression. Because of that, cervical also have some aggravation of the instability and kyphosis, because we need some preservation of facet joint also some another point. I believe that the endoscopic spine surgery, in spite of the sufficient decompression, we can take still can preserve the facet joint sufficiently. And also this may be I think that this advantage we can take this movability of the working channel like this. Then can take some sufficient decompression and preservation of facet joint is sufficient is can possible. But we should checking some anatomical consideration. In the cervical posterior surgery, there has 2 points. One is a foraminal stem decompression, one is a central decompression. We already made a discussion about the foraminal decompression, so many professors and doctors, but we already well known that this V point is a docking point, and some decompression of cranial and caudal is a next step. But there have 2 anatomical nerve structures of those motor and sensory. Always we can check here and also here. Sometimes disc pathology cranial, sometimes disc pathology is caudal. But usually this disc pathology blocking by the nerve root. Because of that, we always checking that this nerve root is very important. You please checking these anatomies. And also another important anatomy of the cervical is vertebral artery. In my clinical study, we can see here the upper lower level is more lateral from the midline. It means that more close from the V point in the upper level. That is, you can see here. In my cadaveric study, you can see here this nerve root. And vertebral artery is very close to the nerve root. If you decompression more sufficiently widely, you can easily contact the vertebral artery and can possibly damage the vertebral artery. That is very serious complication because you're checking this anatomical study. Yeah, and also in the there have some surgical consideration of the cervical operation. Well, firstly, some traction of the cervical, because of that, the traction can make some more widening and some lessening of the widening of the disc space and lessening of the bleeding during the operation, because of many doctors some traction of cervical. But if we can possibly this flexion, we can make a widening, and not traction can possible. I'm always performing this operation. And first docking point is always V point, in spite of the foraminal stenosis and sometimes contralateral foraminal central decompression. Always first docking point is a V point. Then can decompression of the cranial, decompression as caudal. You can see here the cranial and caudal at this point. And you can see here this axilla and this shoulder, cranial and caudal. Actually, to take this wide axilla area, usually it's not easy because of that the pedicle very close to here. Because if you need widening this axilla area, you need some resection of the pedicle. Pedicle sometimes needed. And before operation, you should checking the location of the disc pathology. If disc pathology shoulder, you firstly resection of retraction of here, but usually approach from this axilla area is more safe. But sometimes huge disc located here, some drilling here, some pedicle drilling, and some resection of the lower vertebral body can resection and can possible more easily approach to the discal space can possible. And also, if you hope to decompression of the ipsilateral to contralateral, I already mentioned that firstly docking V-point and drilling outside in over the top technique is very, very important in cervical area. This is very important issue in safety. And the drilling from cranial, then drilling to caudal, and over the top and contralateral, then drilling cranial and drilling caudal, and finally take out the ligament flavum. That is very important, like this. Because of that, the nerve cord of the cervical cord always angle is spinal cord. This is very important. And in thorax also same. Thorax also, if you because of that, the thorax main pathology is ossification of ligament flavum. That is the main issue of the thoracic decompression. Because of that, this docking and cranial drilling and caudal drilling and over the top and contralateral drilling is very important. You can see here the laminectomy is more wide. In my cases of the thoracic OLF, always not drilling here, always drilling this shape and take out by one piece, like this. I will see some cases. You can see here the thoracic OLF case. I have so many OLF cases. Today I will show some these cases of ipsilateral cases. Okay, this point is near here, not drilling from here, drilling here to around here, and then finally take out the ligament bony lamina by one piece. This is very important in the safety issue. And then you can checking some cutting of the cranial part of the ligament flavum, take out the lamina, then you can see the ossification of the ligament flavum here, can take out. Because of that, the endoscopic spine surgery always fluid shooting the center. Because of that, if you targeting the dura, or it means that always shooting the fluid to the dura. Because of that, opening the dura is always final. This case can see some stenosis and ossification of the calcified ligament together. In that case, it can possible. Firstly, decompression from here, then approach to the caudal part and drilling of the vertebral body and resection of here. Now this decompression, then this low vertebral body drilling here. Then you can hear the dura here. And you can see the free dura, and the post-operative you can see some sufficient decompression here. Yes, endoscopic cervical surgery also nowadays performing so many doctors, and this foraminotomy is already doing so many doctors. And also I already mentioned there, firstly docking the V point and cranial drilling, caudal drilling, and checking the nerve root, motor point and sensor point together, always together. And then nowadays, like this, cyst cases can possible. And also, I already mentioned that if we meet so severe stenosis cases or so huge migrate cases, you need some retraction is very dangerous. Because of that, in the cases, we need some resection of these bone structures and the resection of these bone structures. But we can checking that this the resection is more safety because this actually area is more wide. But this anatomical structure is pedicular because we can transpedicular, transcorporeal approach can possible. Resection of here. And then more safely. Then you can drilling of the low vertebral body and some then more safely approach to the foramen and central approach is safely approach can possible. You can see here, if we met like this case, we need some decompression, not only here, we need some resection to here. And if possible, we hope to resection to here, like this. In these cases, also consider so huge disc protrusion migration. In the cases, also it needs some. Okay, here you can see some pediculectomy. Now, some pediculectomy and some here pedicure and can insert the working channel more deeply and some lumbar of the pathology more safely. And also. Okay, this case, some another case. Yes, you can see here some. This case is also some severe spinal stenosis, foraminal stenosis cases. In that case, we need some decompression not only here to here. In that cases, some pediculectomy. Yes, some pediculectomy and some vertebrectomy. And then decompression or can possible. But this only including the foramen. But if we approach hope to unilateral approach bilateral decompression, I already mentioned that we doing some always over the top approach like this. And I will show some of my cases. So you can see there's some stenosis, myelopathy stenosis, this some other cases. And post-operative, you can see sufficient compression. And this case is also sufficient compression. But this cord always exposed in the very close to the fluid targeting because of that. Cord exposure is always final after resection of the cranial and caudal part of the ligament flava. I will show this case. This C3-4 cord injury case with stenosis. Actually, this patient near foot drop state and shoulder drop state. Here, not working. And now you can see here the ipsilateral decompression, and now approach to the contralateral side. But you can see still not open the lateral space. This caudal drilling here. The ligament flavum remained till to near final of the resection of ligament flavum. And this exposure of the dura should brief timing. Should keep the brief timing. Then. This patient, this image video 2 weeks later, the patient can pass away. But this is very important issue. I already mentioned that. Actually, in the endoscopic spine surgery is a fluid shooting surgery because of that. Targeting the dura is very dangerous. This is my cases of some complication because of my fellows. I always talking to not open the epidural space to my fellows. My fellows fail to open the epidural space, and the patient some complication of dura. But because of that, this ligament flavum keep the final to open the dura. This is very important. Yes, in conclusion. Yes, endoscopic spine surgery is developed so much, and also I believe that lumbar pathology near overcome the near completely, but cervical and thorax is still not overcome. There is still learning curve. But because of that, we need research and we need the development of surgical techniques. I hope to introduce this biomed research. Please submit only remain 2 weeks. And 2 weeks later, we have a KNS endoscopy thermal workshop. And also next year, World Spine in Korea. I invite Hyeun Spine Society to this big meeting. Thank you for your kind attention.
Dr. Kim, thanks for your nice presentation. Yeah.